Hello everyone and welcome to the video presentation series titled Bowel Obstruction. The work is catered to MRCS candidates who might find this helpful in revising their exams. There is no conflict of interest and all videos were made for educational purposes only. These are the learning objectives that we will be covering today, so please enjoy. By definition, bowel obstruction can be the partial or complete block of small or large intestines that keep food, liquid, gas, and stool from moving through in a normal way, and it accounts for nearly 20% of all surgical abdomen admissions. The causes of abdominal obstruction can be broadly classified into intramural, mural, and extramural based on the location of the obstruction. Intraluminal causes includes conditions like gallstone ileus, foreign body, and fecal impaction. Mural causes are due to conditions like cancer, diverticular strictures, and intussusception, just to name a few. And lastly, few of the commonest causes of small bowel obstruction, such as adhesions and hernias, are classified as extraluminal. Bowel obstruction can present with colicky abdominal pain that is described as crampy and comes in waves associated with vomiting, constipation, abdominal distension, and dehydration. Absolute constipation is defined as the inability to pass motion, liquid, and gas as a severe form of constipation, which might suggest a closed-loop bowel obstruction if presented with the clinical features stated before. Closed-loop obstruction is describing the presence of proximal second obstruction, such as a volvulus or a large bowel obstruction with a competent ileocecal valve. Closed-loop bowel obstruction is a surgical emergency with a high risk of ischemia and rupture of the bowel walls. Next up, we have volvulus, which is essentially a twist of bowel loop around its axis of mesentery, with sigmoid volvulus being commoner than cecal volvulus. The predisposing factors are age, male gender, neuropsychiatry disorder, nursing home residence, chronic constipation, and long-term laxatives use, and lastly, previous abdominal operations. The table illustrates the comparison between sigmoid versus cecal volvulus. Few of the pertinent points that I would like to highlight are: cecal volvulus has a bimodal age distribution of 10 to 29 and 6 to 79 years old group, due to cecal volvulus can sometimes occur in young individuals who exercise excessively. The management of sigmoid volvulus should be conservative initially, whereas surgery with bowel resection and anastomosis will be the initial management for cecal volvulus in fit patients. We now then take a look at Meckel's diverticulum, which is a congenital abnormality causing incomplete obliteration of the vitelo-intestinal duct. Though it often presents as a painless rectal bleeding in children under the age of 2 and usually asymptomatic in adults, it can too cause mural bowel obstruction as one of the complications. The rule of 2s in Meckel's diverticulum include: it involves 2% of the population, it is a recognized important cause of rectal bleeding in children under the age of 2. Usually the diverticulum is around 2 inches long, 2 feet from the ileocecal valve, and has a 2 to 1 male to female distribution ratio. 1 in 2 of the Meckel's diverticulum will contain ectopic tissues like pancreatic mucosa or gastric mucosa, which risks peptic ulceration at the diverticulum. Definitive diagnosis of Meckel's diverticulum can be achieved by using technetium 99M scan, as known as Meckel's scan. The management of Meckel's diverticulum depends on the diameter of the neck and symptoms. Laparoscopic removal is preferred if the Meckel's diverticulum has a narrow neck and the patient is symptomatic. The technique differs between wedge excision versus small bowel resection and anastomosis. The image on the left shows a Meckel's scan uptake by the gastric mucosa in Meckel's diverticulum, whereas the image on the right depicts a obstructed, malrotated, gangrenous Meckel's diverticulum in an adult. The next pediatric condition is intussusception. It is known as the telescoping of the bowels that occurs commonly in children at the age of 6 to 9 months. It is also one of the commonest pediatric emergency in children less than 1 year old. It has high risk of bowel ischemia and presents as colicky abdominal pain associated with diarrhea and vomiting. Intussusceptions in adults are usually caused by a presence of a polyp or local pathology that acts as the leading point for intussusception to occur. Physical examination findings in children are sausage-shaped mass and red jelly currant stool. Ultrasound of the abdomen is the most sensitive tool to diagnose intussusception, with target sign as the diagnostic feature for it. The first line of management for intussusception includes air insufflation reduction under imaging guidance. If the attempt fails or there are peritoneal signs or other features such as an unstable child, surgery should be considered. Surgery is a definitive treatment of adult intussusceptions. Formal bowel resection with oncological principles is followed for every case where a malignancy is suspected. Lastly, we have pseudo-obstruction on the list, which is defined as acute large bowel dilatation with the absence of mechanical obstruction. Causative factors include electrolyte imbalances like low potassium, hypomagnesemia, hypocalcemia, hypophosphatemia, and hypothyroidism. Offending medications such as opioids, calcium channel blockers, and tricyclic antidepressants can cause pseudo-obstruction as well. Neurological conditions like Parkinson's disease, multiple sclerosis, and Hirschsprung's disease often related to pseudo-obstruction of the bowels. A CT scan of the abdomen should be performed to rule out any potential mechanical obstruction before this diagnosis is made. The management surrounds supportive treatments via symptomatic relief and by correcting the electrolyte imbalances. Endoscopic intervention and selective intravenous neostigmine use if conservative approach fails. Surgery should only preserve for patients with peritonitis or perforation and for those who failed every single conservative management. In summary, the general investigations for bowel obstruction include bloods and observations, abdominal X-ray, erect chest X-ray if perforation is suspected, CT of the abdomen and pelvis with staging if malignancy is suspected. Gastrografin can be used as an investigative as well as a therapeutic approach occasionally. Lastly, MRI scan for local staging if malignancy is confirmed, which is more commonly seen in cancer of rectum, which is already proven on CT abdomen and pelvis. This is an example of cross-sectional CT abdomen and pelvis showing small bowel obstruction with some of the features explained. Last but not least, the overall management of bowel obstruction includes a stepwise systematic approach of A to E assessment, drip and suck with the use of IV fluids and NG tube for symptomatic relief, correct any dehydration to prevent further acute kidney injuries, catheterization to measure urine output and to maintain fluid balance. Other symptomatic control can also be achieved by the use of analgesia and antiemetics. Bear in mind the importance of nutritional support when the patient is new by mouth, but long-term TPN is catabolic, hence definitive management should always be sought. And lastly, patients with bowel obstruction should be managed conservatively first before surgical approach is considered. While we are on the subject of total parenteral nutrition, I have briefly included some of the early and late complications associated with TPN use. These include line sepsis if aseptic feeding technique isn't used. Pneumothorax can occur during the insertion or due to displacement of the line. Cardiac complications, which includes vena cava thrombosis and an infective endocarditis if the line is infected. Lastly, metabolic disturbances and refeeding syndromes are the complications to watch out for when the patient is on long-term total parenteral nutrition. We have reached the end of the video presentation for bowel obstruction. Hope you enjoyed. Thank you very much and till next time.